Imagine you've just been diagnosed with endometriosis. You're told this disease can affect fertility, and someone suggests, why don't you freeze your eggs now, just in case? It sounds like a sensible, proactive move, but here's the reality. For people with endometriosis, especially those with ovarian endometriomas, the timing of egg freezing can make a huge difference to your safety, your ovarian reserve, and your future fertility. Hi, I'm Dr. Abhishek Mangeshikar, robotic surgeon and endometriosis specialist. In this video, we're going to unpack a question I get almost every week. Should I freeze my eggs before or after endometriosis surgery? We'll go through the pros, cons, and real-world risks of both approaches so you can make a healthy, informed decision with your fertility and long-term health in mind. Endometriosis can affect fertility in multiple ways. Inflammation around the ovaries and fallopian tubes can impair egg release and pickup. Endometriomas, also known as chocolate cysts, can damage healthy ovarian tissue over time. The disease can reduce ovarian reserve faster than age alone would. Because of this, fertility preservation is an important discussion, especially if you're not ready to conceive now. Option 1. Freezing eggs before surgery. The potential advantages are you might capture eggs before any surgical loss of ovarian tissue. If your ovarian reserve is already low, this might secure some fertility potential sooner. It avoids waiting months for post-surgery recovery before starting fertility treatment. But here's the big caution. If you have large endometriomas, retrieving eggs involves inserting a needle through the vaginal wall and through the cyst wall to reach the follicles. This carries a significant risk of infection because endometriomas are filled with old blood and inflammatory fluid, and usually they're adherent to exactly the point where the needle will pass through. If infection happens, it can damage the ovary further, sometimes even leading to abscesses or loss of the ovary entirely. The stimulation drugs used in IVF can also exacerbate inflammation and temporarily worsen symptoms. And one more overlooked risk: the act of inserting the retrieval needle itself causes trauma and inflammation. This can worsen adhesions around the ovary so that when the patient eventually does go to surgery, what could have relatively been a straightforward cyst removal becomes a far more complex operation. That compounds the risk of losing healthy ovarian tissue. In my practice, I've seen patients come to me with severely damaged ovaries after egg retrieval through large cysts, damage that should have been avoided with better planning. Option 2. Freezing eggs after surgery. The potential advantages are the disease, including large endometriomas, have been removed, which makes egg retrieval safer and easier. If deep endometriosis is also cleared, the pelvic environment is less inflammatory, which may improve egg quality and implantation rates later. The lower risk of puncturing a cyst and causing infection. The possible downsides are that any ovarian surgery, even in expert hands, can remove a small amount of healthy tissue. You may have to wait a couple of months after surgery before ovarian stimulation to allow full healing. If your ovarian reserve is already borderline low, the delay could slightly reduce egg yield. This is why surgeon skill matters. An expert excision surgeon knows how to strip a cyst wall while preserving the maximum amount of healthy ovarian tissue. For example, in my practice, we use a special technique for cyst removal, which is where we inject a diluted vasopressin solution between the ovary and the cyst wall. This creates an interface between the cyst wall and the healthy ovary, which allows us to bloodlessly peel the cyst away from the ovary, really minimizing ovarian damage. In select patients with very low reserve, we may even consider sclerotherapy, which I've explained in detail in another video. It's all about tailoring the decision to the patient. There is no one-size-fits-all answer. When I counsel patients, I consider ovarian reserve, which is measured by AMH levels and the antral follicle count, the cyst size and location. Is retrieval possible without puncturing the cyst? And severity of symptoms. Can you wait for surgery or is urgent excision needed? There's the fertility timeline. When do you realistically want to conceive? The risk tolerance. Are you willing to accept a higher infection risk to freeze before surgery? Sometimes, if cysts are small, retrieval can be done safely before surgery. In other cases, removing the disease first is clearly the safer path. One of the biggest problems I see is blanket advice. Freeze eggs first always. This comes from fertility specialists who don't deal with the surgical side of endometriosis. They may underestimate how dangerous puncturing an endometrioma can be, or how much deep disease can affect outcomes. On the other hand, some gynecologists say, do surgery first always, without considering how much reserve might be lost if surgery is not done delicately. The safest path is coordination between your fertility specialist and your excision surgeon. In my practice, I directly get on the phone with the IVF doctor and I ask, can you access the follicles without puncturing the cyst? Can you retrieve eggs without increasing the risk of adhesions or infection? If the answer is yes, egg freezing before surgery may be reasonable. If the answer is no, then we plan surgeries first and proceed carefully to protect the ovarian reserve. This collaboration is what prevents irreversible mistakes. Here's what my general approach looks like. While every patient is different, here's the thought process I follow. No large cysts, good access to follicles, egg freezing before surgery can be considered. Large cysts, high infection risk or significant deep disease, surgery first with a fertility preserving approach, then egg freezing once healed. Borderline ovarian reserve, discuss possibility of limited stimulation before surgery, but only if safe to access follicles without puncturing the cysts. A 32-year-old patient came to me with two 7-cm endometriomas, severe pain and a low AMH. Her fertility doctor wanted to freeze the eggs first, but retrieval would have required puncturing both the cysts. We opted for surgery first, preserving both ovaries. 3 months later, she successfully froze 14 healthy eggs without complication. Contrast that with another patient who underwent retrieval through a large cyst elsewhere. She developed an abscess and almost lost the entire ovary. The difference was planning and understanding these risks. Egg freezing can be an excellent tool for fertility preservation in endometriosis, but timing matters. The safest, most effective choice depends on your cyst size, ovarian reserve, and the skill of your surgical team. Never rush into an egg retrieval without first considering the risks of puncturing that cyst. And never rush into surgery without considering the impact on ovarian reserve. If you or someone you know is facing this decision, please share this video. Too many patients have lost precious ovarian reserve or even an entire ovary because the timing of egg freezing wasn't planned with the disease in mind. Like this video, subscribe to the channel, and share it. The right information at the right time can make all the difference in someone's fertility journey.